Good morning. My name is Eduardo Hernandez Rangel. I'm a first-year medical resident at the radiology department at Dr. Jose Eleuterio Gonzalez University Hospital. The case that I'm going to present today is related to a 20-year-old female patient that presents with the main complaint of bilateral itchy eyes. And after that, she went to the ophthalmology clinic, and then they noticed some goiter at her neck. Her past medical history is just chronic constipation, oral neuromas, and mild goiter. And family history is not contributory for the present illness, and social history only tobacco, that she smokes less than 1 pack per year. For her obstetrics information, the menarche was on 17-year-old. Her cycles are regular and just one gestation and one abortion. She doesn't know the cause of the abortion. No known allergies, and she's not taking any medications at this moment. From the review of systems, her general system questions, no fever, no weight loss, cardiovascular system, no palpitations, and no chest pain. On the extremities, there are no contributory findings, and psychologically, she denies any anxiety or depression. At this point, maybe this is not a very contributory information for our case, but here in our hospital, what I think is very important is the thing that we sometimes make the interrogation for our patients, and this might have some relevance at the end. So for this case, I will try to highlight which are the most important findings. First are the bilateral itchy eyes, because this is the reason that she came to the doctor at the first time. Second, I'm gonna highlight the chronic constipation, oral neuromas, and mild goiter. Also, that she smokes, and the menarche, and the abortion. At this point, the important findings are going to be these ones for us. Maybe we can make a diagnosis, not at this time, but let's try a little bit later. Also, the vital signs were within normal limits, maybe some limited form on the low side of the blood pressure, but the rest were normal. And general habitus after physical examination, it's a marfanoid habitus, appears stated to the age, prominent corneal nerves when the ophthalmologist made the examination, oral neuromas that we already described before, and the goiter. The only description for the goiter was that the left lobe was bigger than the right lobe, 2 times bigger. It was non-painful. She presented with a non-painful hard mass with irregular borders, 1.5 times 1 centimeter, with no lymph nodes. And the cardiovascular system, regular rhythm and rate, gastrointestinal within normal limits, respiratory within normal limits, extremities. The extremities were disproportional for the age and the sex, and with long arms and arachnodactyl. And the central nervous system within normal limits. At this point also, what might bring us to some clues for the diagnosis is going to be the marfanoid habitus and the prominent corneal nerves, oral neuromas, and of course the goiter. The arachnodactyl, that it was part of the habitus. This is a real picture of the patient, that if you see, she is very thin. If you see the disproportion of the long arms here, it's below the waist, and the neuromas that we can see on the lips. The goiter is not really evident at this point, but in this picture, I'm sorry, but it's a little bit bigger on the left side of the thyroid gland. Then, plus, we can add to these signs the marfanoid habitus, the prominent corneal nerves, the oral neuromas, and also the goiter that we already described. The labs were within normal limits, no really relevant findings. And the patient performed an outside ultrasound in another clinic, and the report was not really substantial, but with some relevant information that might help us. It was performed on April 23rd, and the description was for the right thyroid lobe that it was two masses that were hypoechoic, circumscribed nodules that were very well circumscribed and with microcalcification, and the most representative was 5 millimeters. On the left side, also they found two ovoid nodules that were heterogeneous with cystic and calcified areas, and this one where the most representative was 25 times 15 millimeters. The report came with no TI-RADS score, but if we try maybe just to make the exercise for the TI-RADS, we can maybe make an approach of this one. If you remember the TI-RADS, it was based on the composition, echogenicity, shape, margins, and echogenic foci. For the patient, if we make the sum, at the end we will have in total 8 points. The last one, the foci, we couldn't make it because it was not in the report, but it was taller than wider and mixed nodules. And at this point, the recommendation for the TI-RADS is fine needle aspiration if it's more than 1 centimeter, which basically is the case of this patient. At this point of the patient history, she came to our clinic and we performed a biopsy. The results of the ultrasound fine needle guided biopsy, especially on the left thyroid lobe number 1, came after the cytology report with medullary carcinoma with the Bethesda score of 6. That basically is a malignant tumor. Then, if we make an addition of our findings, now we have our first diagnosis that it's going to be medullary carcinoma. Now we have the reason of the goiter of our patient. Let's try to continue with the medical history. Then, thyroid cancer, as we know, it has many variants. The most common one is the papillary, then the follicular, and the medullary, it is only for 5% of the population of patients with thyroid cancer. It is from the C cells that secrete calcitonin, and it's associated with multiple endocrine neoplasm type 2 and also familiar medullary thyroid carcinoma. At this point, what must bring our attention is that, first of all, it's not a very common cancer of the thyroid, and also it's associated with other endocrine manifestation. Just a reminder, what is multiple endocrine type 1 or Werner's syndrome? It's all the tumors from the P's, they call the P's, that pituitary, parathyroid, and pancreas. Then our patient doesn't have a MEN1. The MEN2, it's medullary carcinoma that our patient has, parathyroid hyperplasia, and or adenoma, and pheochromocytoma. At this point, our patient only has medullary carcinoma. We don't know about the pheochromocytoma, but we are sure that there is nothing on the parathyroid gland. Then, if we go to the MEN type 2B, or also called MEN type 3, we have that it's composed of medullary carcinoma, it's Marfanoid syndrome, mucocutaneous neuromas. If you remember the first three, our patient has those ones, but does our patient has pheochromocytoma? Then we can maybe make an approach to a syndromatic symptom, a syndromatic diagnosis. Then this is the question. This is the reason that a lot of other specialties like endocrinology, internal medicine came to the radiology department. First of all, does the patient has pheochromocytoma to make a diagnosis of MEN type 2B, and what to do with the medullary carcinoma, because as you remember, it's malignant and it has a very potential, it is very potential to metastasize. Then what to do first? Treat the carcinoma or go and find the pheochromocytoma and treat it. If you remember for the clinical history, the patient has normal vital signs. For the history of pheochromocytoma, most of the patient will have hypertension and tachycardia with other symptoms, but those are the most common ones. So what to do? We perform a thyroid CT scan here at the department, and we just found that there was this nodule that the measurements were here 3.8 centimeters on the taller than wider, and it's a heterogeneous composition in a CT scan of this actual view with some cystic components, and also it's not very visible here, I'm sorry, but with micro calcification on this point. So it's a mixed composition of this nodule, and if you see here, you can basically confirm that it's taller than wider, and it was on the region 3 on the left thyroid lobe. Then we decide to perform a CT scan, and if you see here, we found that there is a very big dilation of the colon. It was more than 15 centimeters, and if you remember the picture of the patient, she was completely asymptomatic, and she was very, very thin. The only background that we got is that she got chronic constipation. When we performed the direct examination of the part of the adrenal glands, we went to see that, that the composition, it was not of the normal adrenal gland. All the adrenal glands, I will show you later, they are triangular, and they are very unique in their shape. We don't have to see any nodular compositions, as we can see here in this non-contrast CT on this actual view. If you see, this is the adrenal gland that is not in a triangular shape. If you go to the next cut, you will see here the same thing. It's like some kind of lobular shape. If you go in a coronal reconstruction, you will see that it's bilateral, this composition. It's more evident on the left. On the right side, it's more lobular, like circumscribed, but it's very well circumscribed. And you can see here the same on the other side, that it's not very well triangular. It's supposed to be. At this point, the endocrine department came to us and asked, "Is this this is a pheochromocytoma, but it is bilateral? It is or not?" At this point, we cannot answer that question. We only know that the shape of the left adrenal gland is not what it's supposed to be. But in order to perform a better evaluation, you need to contrast your patient to get the information of how are the enhancement and the Hounsfield units on the adrenal glands. We can have a better view of the right and left adrenal gland. And we make the measurements. If you see here, we got around 93 Hounsfield unit for this adrenal gland. If you remember, the adrenal gland is composed of two sides, the cortex and the medulla. The cortex is basically lipids, and also the medulla, and the medulla produce norepinephrine and epinephrine. And basically, it will supposed to be more lipids than any other component. And here, the medulla in a non-contrast CT is showing us like a soft tissue component in the Hounsfield unit. On the contrast side, measuring it also shows soft tissue components, or like a soft tissue components. This will help us to make the diagnosis later. Just to make a review of the pheochromocytoma. to try to understand if our patient got bilateral pheochromocytoma. It's a tumor for the chromaffin cells on the adrenal medulla and extraadrenal paraganglia. Most of the time, it is within the adrenal medulla, and just 10% of them will be outside of the adrenal medulla and along all the sympathetic chain, anywhere from the neck to the urinary bladder. Most of the time is subdiaphragmatic, and it's also related to the sucker candle near the urinary bladder. Basically, this organ, if you remember, most of the time is located at the bifurcation of the aorta or below the inferior mesenteric artery. The hereditary pheochromocytomas are small, are bilateral, and the adrenal lesions are present in a younger age. So this might bring us our attention that bilateral pheochromocytomas are hereditary. So maybe we also need to think about the family of the patient. The pheochromocytoma is the tumor that we call, that is from the rule of tens. 10% will be extraadrenal, that we call them paragangliomas. 10% will be bilateral, 10% will be malignant, and 10% extra-abdominal, 10% familial, 10% on the pediatric population, and 10% silent. 10% will have autosomal dominant transmission. On the ultrasound, it's very difficult to make a diagnosis. We only have a suspicion because it will be variable echogenicity, with the majority of them will be hypoechoic. And if you go intentional, you might find some hemorrhage and might be echogenic on this kind of pheochromocytoma. It will be round, well-circumscribed mass with cystic components, and we might identify cystic components. On the non-contrast enhanced CT, we might find soft tissue attenuation, and if you remember from our patient, it will be more than 10 Hounsfield unit. And also, there will be areas of increase of density because of some hemorrhage. Will be or might not the decrease of density when there is cystic degeneration or necrosis, and there will be areas of circumbilineal calcification. On the contrast enhanced CT, will we find heterogeneous enhancement due to the tissue necrosis, cystic degeneration, and hemorrhage. And also, this will be important here, the hyperenhancement will be more than 110 units in an active pheochromocytoma, and the delayed washout kinetics will be present here. I forgot to mention that in our patient, the delayed washout kinetics was more than 50%, so it was presenting a delayed washout kinetics. So does this will help us to make a diagnosis? In order to do this, we might come to our differential diagnosis. The first one is going to be adrenal carcinoma. Why? Because adrenal carcinoma might come with a delay in the washout kinetics. It is rare, it is usually unilateral, it is very large, and also it presents a lot of calcification, as we can see in this actual CT. It is also metastatic by the time that we make a diagnosis, and most of the time it generates metastasis and thrombus to the inferior vena cava. Another differential diagnosis is adrenal metastasis and lymphoma, but the adrenal metastasis most of the time will generate symptoms to the lung, or it's metastasis from the lung, from the breast, renal cell carcinoma, and melanoma. And our patient doesn't have these ones, so we can say that it is not from metastasis. The adrenal lymphoma is usually part of diffuse disease. Also, the patient will have a lot of symptoms, and the composition is very unique and uniform that in a CT scan that the patient didn't have, and it's bigger. Other that are less common is adrenal myelolipoma, that it's a benign tumor. It's most of the time composed of lipids, and the Hounsfield unit enhancement is less than 100 to less than 30. And the adrenal hemorrhage, but in the adrenal hemorrhage is related to septicemia, burns, trauma, stress, hypertension, and nothing of this one is present in our patient. And at the end, adrenal TB or fungal infection. But in these cases, because of form calcification, it will be calcified adrenals. So again, does our patient has pheochromocytoma? At the, at the end, we came with these normal adrenals. It's just a picture. If you see, it's very well shaped in a triangular form. And just for anatomy reminder, the adrenal, the left one is less than 6 millimeters, and the left one is less than 8 millimeters. In our patient, they were bigger, more than 1 centimeter each. So at the end, after we consult them, they came with these labs that are specific for pheochromocytoma, and all of them were elevated. All of them are related to basically to pheochromocytoma, especially the metanephrines that were elevated. And just to consider in this patient, if you remember, our patient also has enlarged corneal nerves, and if you see just in the middle highlighted, it's related with men type 2B. Also, our patient got megacolon that is also related to men type 2B. And at the end, pheochromocytoma might not be related to any of the usual findings that we might find in any other CT. That's the reason that they call an imaging chameleon, because most of the times it might not present with the regular findings. So again, with the important findings from the past in our patient, we now have a real diagnosis that it's men type 2B, because all the findings that we have in our patient and also all the findings in the CT scan. In summary, clinical history remains a key factor for diagnosis. Ultrasound is operator dependent, and as in this patient, it might delay the treatment, and it must be performed by radiologists who are the experts. And multidisciplinary teams and communication will always be in the benefit of the patient, and as in this case. Thank you.